Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better in veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
Dana asked, any tips for large breed incisor extractions? Can you make a flap on those teeth?
Yeah, great question, Dana. That maxillary lateral incisor is super difficult, especially in large breed dogs, especially in any size dog that's brachycephalic, because the bone is so much more thicker, it's more cortical, and so it's definitely difficult to remove. So let's use that as an example. Basically, what we prefer to do is work on the mesial and palatal side of that. We start off on the palatal side between the maxillary third incisor and the second incisor, and we'll, even if it's a large breed dog, we'll probably use a number 2 satyr elevator. Excuse me. And that starts our forceful path down that periodontal ligament space. So it creates a little space for us to use our next size, number 3 luxator elevator that is made for strong enough to handle elevation of that tooth. And in progression of the technique, you want to use that void in that bone that you created with the number 2. You want to put the number 3 in there in the same spot and use your torque and push it further apical as you go. And then once you start to get more leeway there, then you can use a number 4 if the patient's big enough and finish it off with a 4. You shouldn't have to go to a 5. Your 4 fits in a fairly large, medium-sized dog or large dog really nicely around that tooth root. And that's how you choose what elevator you use, is how big is the tooth root and how much does that contour match the tooth root on the elevator luxator. So that should give you a really good basic approach, but it's not easy. If you listen to our recommendations in general, once we get the luxator elevator in there, forced in there with this kind of motion, then it's a slow progression, not wiggling, but in one direction with that elevator. And we recommend generally 15 seconds. But in that tooth, we're looking at 2 to 3 minutes per elevation. And you don't have to squeeze that thing and crank down on it. It's not that type of motion. It's just make sure that you've got a good grip on that. And then just without just cranking down on it, just use your wrist to turn and keep that pressure on that tooth root. If you take it off, you've lost everything that you've just done. So you want to count to 15 seconds. You want to count to 2 or 3 minutes, depending on what the tooth is, and make sure that you're cognizant of how long that elevation technique is lasting, because it can feel like a lot longer and you'll let go and then you've lost a lot of the work that you've already done. Now, that being said, what the thing that we use every time on that tooth is a mechanical periodontal called a vet tome. And that vet tome is like a jackhammer, and it's sharp to a certain extent. It's not like a scalpel, but it's sharp enough that it'll go down that periodontal ligament space with minimal physical force on your end and make it so much easier to extract that tooth. We also use that on all the big teeth. especially on the lingual aspect of the mandibular canine tooth, which can be difficult extraction as well. That's available on our website, Dr. Brett's Pets. Everything that you guys use, or most everything that you guys use in practice, are on that one website, and you can order directly off that website. I say we have the best customer service in the industry there, and our prices are as good as anywhere else. So the Vet Tome, you can get that on there. You can get all your burrs, you can get your hand pieces, your high-speed system, everything that you can imagine, you get on that site. You don't have to look and go to different sites and try to find stuff. And that's why I did that originally. We'd be in live, and people would always ask, where do I go to get this stuff? And so we had a PDF that sent people to probably 12 different places to get it all. And so I decided for our students, just to put it all on a website and make it super easy. So that's where that was born. Anyway, enough tangent. Jen, go ahead on the next question. Hope I answered that okay, Dana.
All right, Debbie, what do you do if a root tip goes into the mandibular canal?
Debbie, the take home here is if you use the technique that I described, you'll never have that problem. But if that's happened in the past and you're asking for the past, then the best thing to do is cause no harm and refer it. And just close it up and refer it. Unless you've been to wet labs, unless you've been through our Veterinary Dental Practitioner Program and you've had a lot of training, then you can go out after those things within reason. Some of them you would still not want to go after. And that would be our advanced course that we give every 2 years that trains you how to do that by going directly into the mandible from the lateral aspect and removing the teeth roots that way. But you just don't want to cause harm. If you've managed to get that thing in there in the first place, it's going to be, you're probably not prepared to go in there and get it out. So that's where referral comes in.
Carol asked, any tips on extracting the caudal root of 310 and 410 in a small dog?
Carol, that's a great question. With that tooth, the easiest way to extract that, and generally that tooth's got perio. You're not going to be extracting a fractured 310 or 410 because they just don't fracture those teeth. Very rarely do we ever see that. So you're going to have some periodontal disease. One or both those roots are going to be compromised from a bone standpoint. And so my approach, and this is how I do it, and this is how I recommend that you attempt it and get used to doing this. You can do this on a cadaver as well. And it's more challenging because there's no bone loss, but it's still a very good way to practice this. I don't do a flap to expose bone on this. I do a little flap with a periosteal elevator right in the furcation, enough so that I can retract that back while I'm sectioning that tooth. And I'll section it depending on how big the patient is with a 701L burr or a 699 burr. And then that section allows you to get your luxator elevated. You're going to want to use a 1 or a 2, depending on how big the dog is, or 1.2 to 1.5 or a 2, and just gently place that between those two roots, and with 2 or 3 fingers, do your elevation, one root against the other, and then turn that elevator around and do the other root. And that will generally give you plenty of mobility so that you can get your extraction forceps on there without a flap. And as long as you're careful and as long as you don't put too much force on there, then you're going to be successful pretty much every time. Or you may, in your learning journey and you're trying to apply that, you may get impatient and you may try to put too much force on there, but you'll learn that you can't put that much force on there again. And the next time you do it, you'll be more adept at being able to gauge that force. And before you know it, that's going to be a fairly easy extraction for you. I always said, it's probably in this course. We did this course several years ago, this simple and surgical extraction course. Until the last several years, I've always done a flap because that's the way I was taught. And I fractured way too many of those, even with a flap, because it seemed like you remove the bone and then you get down to where the marginal bone level is that you just created, and it'd fracture there. I was frustrated with that and started doing this, and this is so much easier. I used to say that is the tooth that I just hate to extract. And it shouldn't be if you use that technique and you get used to that technique. So great question, Carol.
Nancy asked, which teeth do you use envelope flap versus releasing?
The vertical releasing incisions we do, and actually, I need to step back a little bit. I think Nancy asked a question about the incisor as well. And we do flaps on those if we fracture a tooth root. So you would have a vertical releasing flap if you end up fracturing that tooth root, where you're doing it like we showed on the canine tooth. You're on the mesial aspect of that. You do one vertical releasing flap, and then you can take and extend that a little bit distal so that you've got a triangular envelope, kind of like you do on the canine tooth on the maxilla. And you can open and you can expose the bone and remove some of the bone around that tooth root. And then you can go circumferentially around the tooth with a burr and then wedge it out of there. So that would be one example that's only if you fracture. Then the other two are pretty simple, the maxillary canine, maxillary fourth premolar.
Monica asked, do you have tips on removing the lower canines in a cat with a little bone support?
Yes, that would be, I think that would be more appropriate, more common in the dog than the cat, because what happens in the cat is we get vestibular bone expansion. We don't really get that profound bone loss adjacent to the tooth root. It's more vestibular bone expansion. And generally in cats, if you have perio, which is the vestibular bone expansion, you're going to have tooth resorption apically first. It's going to work its way to the crown. If you do experience that, let me back up and just do that from the dog's standpoint, because I just really don't think you'd experience that very much. And if you do, as one side, you're probably dealing with neoplasia. So keep that in mind. But for a dog, many times you'll see that bone loss. It's circumferential. It's all the way down to the apical 1/5 of the tooth roots. You've only got bone around that one little bit. But if you try to put a lot of torque on that, you don't have a lot of bone support, and you can fracture that in small dogs in particular. So the thing to do is to expose the tooth with a flap and remove more bone. So what you're going to end up doing is getting up under your most distal portion of bone removal and ledging underneath that ledge of bone right next to that mandibular foramen, and then very gently, the same technique that I just mentioned for that mandibular second molar, use your small 1.5 elevator and just wedge that thing out of there really carefully, and then go in afterwards to clean all that debris up. And I should say, if you're not comfortable with that, if you're not super comfortable with removing bone apical to the mandibular foramen on those mandibular canine teeth, which many people aren't. Many people that we get referrals from, many people that every dentist gets referrals from, is from the mandibular canine or the mandibular first molar, or both, where people just are not comfortable removing those. So if you're not super comfortable with either of those teeth, in small breed dogs, those are potential jaw fractures. You wouldn't want to go after the apical portion of either of those unless you're super comfortable. You'd want to refer that.
Ellen asked, are products like Clinderol or barrier sealants really helpful or not worth it?
Yeah, Al, sorry about my voice. I'll gradually get out of it, hopefully, before we end today. But we used to use doxyrobe, and we don't use that anymore. That has been proven with a really good study done at the University of Wisconsin, where they looked at placing doxyrobe or placing Clinderol in pockets after closed root planing, and they found that it's no closed root planing subgingival curettage. They found that there's no benefit there. So we stopped using doxyrobe quite some time ago. And fortunately, within the last year, we've had hyaluronic acid in a gel form that's been introduced to the veterinary profession to use for that pocket. So we place a let's say we're adjacent to a maxillary canine where you have that big zone of attached gingiva. You place a periodontal probe in there, then it goes in 5 millimeters and it bleeds. That is a pocket that needs closed root planing. It needs subgingival curettage. And once you get that cleaned out, you place Periovive, which is hyaluronic acid, into the defect, and that will help regenerate that attachment. And it does so very effectively. Hyaluronic acid is present in all tissues. It's there. It has multiple roles. Doxyrobe was a physical barrier that prevented the gum tissue from migrating down into that pocket after you cleaned it out. You don't want gum tissue down in that pocket or endothelial tissue in that pocket. You want it to be nice connective tissue so that it reattaches to the substrate and eliminates your pocket next time you see that patient. And that for years we didn't use anything because Doxyrobe was proven not effective. And that's also in humans. But now we've got Periovive and we can use that for that purpose. We should be using this compound in almost every single periodontal case. We definitely should be using it in every single pocket that we clean out, whether it be more advanced where you're doing open root planing and you're actually cleaning that tissue out of bone and you're trying to regrow bone. We place that Periovive in that pocket after we clean it out in an open root planing, as well as a closed root planing that we're talking about right now. So if you'd put that link in there, that's what you use now. What's the other compound? I can't even recall what the name is because we've not used it. But some of you will know what I'm talking about, where you place it and you don't have to place it for 6 months. That's in our colleague group as specialists. I don't think anybody uses that, and there's just no benefit to it. But they did a good job marketing it, and so a lot of people use it. But we feel it's a waste of money for the client. And one case in point, it supposedly lasts for 6 months. And the periodontal research is for a period of 6 weeks. So there's no substantiation of those claims.
Okay. Can you ask, how long should a tight fracture of a maxillary canine tooth take in a big dog? And what's the best burr to use?
So assuming that it's just fracture, there's no perio, in general practice, it would not be at an entry level, it would not be unheard of for that to take 50 minutes total from the start to suturing. Once you get good at surgical extractions, you maybe taken a wet lab, you've worked with some cadavers, then 25 to 30 minutes would be really good for general practice. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.